Assalamu alaikum. Once again, I'd really like to thank the organizers for giving me a chance to present. I'm privileged to be here in front of you and to talk about something I'm really passionate about, and which is personalization in terms of treatment for inflammatory disease with a specific emphasis in terms of rheumatoid arthritis. When you talk about biomarkers, I could have easily talked about metabolomics or microbiome, but I'm going to choose genomics because to some extent this is what I do in my lab regarding psoriatic disease. Most of what I'm going to refer to is rheumatoid arthritis, but you'll see a little bit of psoriasis and psoriatic arthritis put in there because it's something that I'm really familiar with. So these are my relevant conflicts of interest. They're not really particularly important for this talk. So again, let's ground it by a case. It's basically a 52-year-old female with rheumatoid arthritis. She's failed triple therapy, started on adalimumab, had secondary failure. You're wondering, gosh, what do I do next? And the question that's really being proposed here is, can biomarkers in any way, and particularly genomics, help in guiding therapy? So what do we do when we're in a bit of a quandary? So someone older like me, we would go to a senior physician, and we would, about 20 years ago and say, well, doc, what would you do in this particular setting? In other words, the senior physician would say, in my experience, this is what I would do. Our younger physicians now are looking for a network meta-analysis. They're so used to looking at evidence-based medicine, they're saying, what is the pooled experience from the clinical trials along with real-world studies? But where things are going potentially is with respect to personalized features. What are the characteristics of this particular individual? Based on the characteristics, can I choose the right therapy for the right person? So the benefit of looking at precision medicine is that we're going to go from an organ-based approach, in other words, to some extent the same disease entity in terms of pathophysiology, rather than the gastroenterologist, the dermatologist, and the rheumatologist looking at it, to a pathway-based approach. Unfortunately, and as you're aware, a lot of our diagnostic tests really have poor positive predictive values. We really need to think about doing some of these tests, because I don't think it actually helps in terms of elucidating what it is that we're trying to do, and it's actually creating some noise in the background. But specifically, are there any markers that will actually help us with respect to therapeutics? So why are we talking about this right now? Because this has been a dream for many years. Well, first of all, technology has driven costs down. With further investigations, and even in polygenic diseases, we realized that genetic determinants are important, even for multifactorial disorders. And there's been a huge explosion in terms of AI and analytic abilities, which are now accessible to a huge number of individuals. So is this possible? Is it possible to actually have some sort of biomarker or an omic profile prior to you prescribing a drug? So one of the issues related to it, and it doesn't always have to be with response directly, is if I were to tell you that this patient's at risk for severe progression, in other words, they're in the top quartile of significant progression for rheumatoid arthritis, you may say, okay, maybe I'll use combination biologics. In other words, biologics with a concomitant DMARD, or maybe I'll start biologics earlier. And so it does make a difference if we can actually predict who's going to have more severe disease. So this is one particular study that actually shows that. And so what they've actually done here is looked at patients that had erosive disease, look at the upper quartile, and did a GWAS study. And so they used 43,000 markers, which seems like a lot of SNPs, but technologically, actually, that's not that difficult. And what they've actually found here is that in particularly people that are young, it's actually a better predictor in terms of disease progression than being ACPA positive or having the HLA-DR-beta1 allele as by the serine mutation. So it's possible to actually predict it's superior to the ACPA in terms of who's going to have disease progression. Can you pick it with one particular marker? You'd be very, very lucky if you actually found it. So the markers that we actually pick are ones that are strongly associated with our disease. So for instance, we have known for a long time that HLA-CW6 is associated with psoriasis. So that particular genotype actually does predict response to adalimumab it does predict response in terms of adalimumab versus ustekinumab. And how does it actually do it? It's in HLA-CW6 negative individuals. You can see the difference in the score to your left, a little bit more pronounced in terms of the skin improvement in patients that have psoriatic arthritis, oddly enough, than those that have psoriasis. And this finding has been validated subsequently. Is there anything specific in rheumatoid arthritis? Well, we know that IL-6 inhibition is very effective for rheumatoid arthritis, and so they subsequently have looked at SNPs related to IL-6, and there's one particular SNP, and when you have the G allele, it's actually a lower response. Fair enough. But are these clinically actionable? They're really not, in the sense that the positive predictive value for these are relatively poor, but they're certainly of interest and gives us some enthusiasm at looking at things further. This was a study that was noted before by Dr. Achara, and this is looking at psoriatic disease, where they just looked at cell types. And if you can identify through flow cytometry a Th1-dependent signature as compared to a Th17 signature versus neither or both, and give the subsequent therapy, what the Japanese colleagues have noted is a significant improvement for targeted therapy based on flow cytometry. This is very exciting if they could validate it further, and this is being moved forward by the British group in the Optimize study. There's a little bit of skepticism, to be honest, that just identifying the cell type will do it. So they have added another feature, and that's looking at the specific cell types and the RNA sequencing related to it. So we'll have to see what happens when this study comes out. To a certain extent, looking at CD4 transcriptome is something we've actually done in our lab. So we actually consecutively look at patients, isolate their CD4, CD8 cells, do expression. And so our first study was looking at comparing secukinumab versus TNF agents. And what we did report almost 2 years ago now in scientific reports is that we can distinguish response to secukinumab, but we had a harder time because the TNF agents are a bit more pleiotropic, determining a clear response to anti-TNF agents. The issue with this is that we actually look at thousands of transcripts, and you need to have this validated. Once you actually have to have it validated, you want to study it prospectively. So we're excited by it, but just cautiously optimistic because we still need to do a lot of work related to this. So now what's happening specifically in terms of rheumatoid arthritis? Again, it's the transcriptome that was used by Ann Barton's group, and what they're actually looking at is you're going to initiate adalimumab for patients that are bio-naive, and they're going to look at the change in transcripted profiling before starting adalimumab and afterwards in 70 patients, okay? And so on the top is the baseline expression profiling. On the bottom is what happens at 3 months. And you can see that for adalimumab good responders, there's much more of a pattern than adalimumab non-responders. And this was based on about 114 transcripts that they actually looked at. So this is very, very interesting, but it's not validated. Again, they're looking at thousands of genes that have been expressed, and we really want to see this being confirmed before we can take it forward. A slightly more elegant study is the one that's presented here, and it's looking at early prediction response to anti-TNF, but this time they're using multiple omics, and they're bringing machine learning into the mix. Really cool design in a small number of patients initially, so they were all females. There were 39 females, and if you look at the volcano plot, and you look at the red versus the blue, you see that there's differential gene expressions that are being underexpressed or overexpressed, respectively. The more interesting finding is here, though, and that is if you compare the technologies, transcriptome versus identifying the cell in terms of flow cytometry versus proteomics, It's the transcriptome that actually gave you a better response. And then within the transcriptome, you look at non-response versus responders. The non-response actually has less variability. And we found this over and over again, that it's probably initially going to be easier to identify someone from a genomic perspective that is not responding as compared to a super responder. Okay? And that's certainly of interest and something to think about. So they identified one particular gene that's important in terms of cell adhesion, and they took 80 patients then, and they prospectively did that profiling, and the area under the curve was 0.81. That's pretty good. That is pretty good for one transcript and gives us some hope that maybe they are in the right area. Again, validation is important, particularly in a different setting. An even more intricate study is actually done by the Dutch group, again using multi-omics, and now using machine learning to look at whether you can predict adalimumab or etanercept therapy in rheumatoid arthritis. Once again, these patients were bio-naive, okay? And what they did is they looked at patients that are bio-naive, and they gave them either etanercept or adalimumab. Prior to getting the biologic agent, they isolated the CD4 cells, CD14 cells, and they did two tests. They looked at the transcripts, or RNA profiling, and they looked at the DNA specifically regarding DNA methylation, okay? And then based on the responders versus non-responder analysis, they were able to determine a signature for etanercept, and they were able to determine a signature which was different for adalimumab. Now, if you happen to fail etanercept, they were going to give you adalimumab. If you happen to fail adalimumab, they were going to give you etanercept. But the question that they asked is, if you actually had failed and I was switching therapy, and we had developed this model with your initial biologic agent, how successful do you think we'll be in predicting response? So of the 80 patients that were in this study, 9 failed therapy. For those 9 that failed therapy, if you do it in terms of the transcript profiling, their accuracy rate in predicting response versus non-response was 90%. That is excellent. That is really, really good. I'm not sure if we could have predicted someone that has actually failed one biologic agent, their prediction 90% of the time. If you use DNA methylation, it was about 78%. Very, very established group with Tim Ratske. We'll have to see how this study rolls out, but again, quite exciting in terms of the development. This is the best study, however, because this is a randomized controlled trial. It was open label that used a stratified biopsy-driven, biopsy being the synovial biopsy, to look at whether after you fail a TNF, you should give rituximab or tocilizumab. Can you actually predict the response? So what did they do? So much of the basis of this work had to do with this synovial pathotype that was being championed by Dr. Constantino Pitsalis. And so as you're aware, he sort of looks at the histology and identifies this lymphoid myeloid aggregates, which he calls B-cell rich. And B-cell poor is defined as when you have very low amounts of lymphocyte, whether it's a diffuse myeloid or a quasi-immune, where you have a lot of mesenchymal and fibroblastic cells around. So in the histology diagnosis for this particular randomized trial, B-cell rich was lymphoid myeloid cells. B-cell poor was a combination of diffuse myeloid as well as this quasi-immune high fibroblast. So that was the histology type. He also did one other thing. He took the synovial biopsy. There are 79 transcripts that'll give you a B-cell signature, and he defined B-cell poor and B-cell rich based on RNA sequencing. So going into the study, he felt that if you were to be B-cell poor, the study was powered such that it showed a difference in terms of tocilizumab being superior to rituximab, because he felt that rituximab would help in a B-cell rich population. What did the histological classification show? A higher response rate, a response being a CDAI of 50%, for the tocilizumab, but it was not statistically significant as compared to rituximab. If, on the other hand, you use RNA sequencing, that was quite significant. So the p-value was 0.035, with 63% reaching a CDI of 50% as compared to 36% for rituximab. The study goes beyond that. So this was published in the Lancet, and a further analysis was done, which was presented in Nature Medicine. When you actually look at the specific pathotypes for the B-cell pore, those with diffuse myeloid cells actually did much better with tocilizumab as compared to rituximab, and this is even more exaggerated if you were to look at the RNA sequencing. If you were to look at lymphoid cells, you may get a little bit disappointed in the sense of maybe you thought the Ritux should do better. When you actually look specifically at the molecular signatures for B cells, it is actually greater for rituximab responders, but not necessarily with the histology. In other words, histology is great, but it does not supersede the RNA sequencing. The final thing we actually learned from this study, and as we all know clinically, there's a subset of patients, no matter what we do with them, we can't make them better. They're failing all biologics. A very important story here, because you actually look at non-responders. It's right to the very last column there, to your left. These cells are enriched with mesenchymal and fibroblast signatures. Okay, and that's why they're not getting better. They're post-immune. They're actually failing tocilizumab. They're failing rituximab, because these are all responders versus non-responders, which kind of makes sense in terms of we need new therapeutics for these patients. It's also telling us that we probably need to start early before you get these changes. There's other things that you can do other than RNA sequencing. For instance, you can do single-cell sequencing. The single-cell sequencing in the subset showed that there are specific fibroblasts that are not responding well. You can also do something called spatial transcriptomics. You can look at the biopsy, and there's a very interesting sublining in super responders. What they have is TNF-soluble receptors in the sublining of the synovium. If you have that, the TNF antagonist bind, and you get a very good response. So I'm not saying that the transcriptome is the only answer, but in terms of single-cell sequencing and spatial transcriptomics, it's harder in terms of a clinical application, but still quite exciting in terms of how things are developing. It's also telling us, and this is a slide from York Shett, but others have thought about the same thing, and that's the initiating cytokines are different from chronification. You really want to get to the disease early, and at the early stage, molecular phenotyping may actually help as compared to when you get the mesenchymal or fibroblastic changes, it gets a lot harder to turn things around. Finally, it's hard to talk about genomics unless you talk about when to refer to a geneticist. Even for a polygenic disease and even for adult physicians, I think there are times when we need to think about it. That's when we see something that has a family history that happens early, and then all of a sudden, if a manifestation is rare, if it's super early or if it's difficult to treat, think about a monogenic cause, because there are still autoinflammatory sort of endophenotypes that sometimes mimic rheumatoid arthritis. And the reason why things aren't getting better is maybe a cytokine like IL-1 may actually significantly help that patient. You may be able to capture it using the genetic panels or even a whole exome scan. So if something is familial and early, or familial and rare, or familial and it's very difficult to treat, it's worthwhile thinking about that. So in summary, I really think there's a lot of excitement and a lot of exciting research that's being done, but unfortunately nothing is prime time. There's nothing I can tell you that you can take today and do and predictably say that you're going to respond or not respond. What we really need to do is use a multi-omic approach. I think machine analysis is very, very hard, so we really need bioinformaticians to actually help us analyze this and help model it. We also have to think about adding on to, especially for understanding the disease, spatial transcriptomics, as well as patient data and imaging. It just cannot be molecular data. And then, hopefully, we will lessen this ingenuity gap or as John Isaac often says in terms of rheumatoid arthritis, this precision gap that actually exists in rheumatoid. And so can we actually help this lady? Not at the present time, but you could have potentially identified an adalimumab responder, and by a biopsy, we can potentially direct them towards tocilizumab versus rituximab, but it's not there at the present time. Part of the reason, and this is my last slide, that it's not there is I think we need community buy-in if we're actually going to do this. So what is it that we need? We need the patients on board, because to do a full exome, for instance, you're going to unmask other genes, or even there is insurance-related reasons as you're trying to help someone. You also need infrastructures in terms of informatics. You need buy-in in terms of the hospitals, because these are costly initially, and you need a lab to do it. So unless we have these peripheral things in place, we can't really think about offering this service specifically to our patients. Thank you so much for your time.